Thanks. I apologize for the IT problem. So I'm going to talk about the sleeve gastrectomy, the long-term outcomes. I'm going to try to do it briefly and a little bit more dynamic because it's very complicated to summarize in 15 minutes outcomes after sleeve gastrectomy. So it's been said many, many times today that it's been a really rapid shift on type of operations around the world. As Dr. Corcelles still, still gold standard, the commonest operation in the world. Data from 2015 to 2020, 60% sleeve versus 22% Roux-en-Y gastric bypass. So there's huge data talking about early and midterm outcomes of a sleeve. And the data that we have shows at short term no significant difference in weight loss and type 2 diabetes remission. However, we need to acknowledge all these short midterm studies are observational and non-randomized controlled trial, meaning that there is lack of high quality studies. So just put attention on that slide. I think this is the best evidence we have so far about long-term outcomes after sleeve gastrectomy. I'm going to summarize briefly all these 7 papers. I think that any bariatric surgeon that does sleeve gastrectomy should be aware about these 7 studies. The first one comes from Stacy Brett-Howard from the Cleveland Clinic. This is a retrospective study evaluating 217 patients with type 2 diabetes, and those patients were followed from a time of 5 years period. So the study shows if we look at weight loss, we see that sleeve gastrectomy had less weight loss than Roux-en-Y gastric bypass. Again, that was a retrospective study only on diabetic patients. Stacy and the team showed outcomes at short term, and at that time it was called long term, 5 years. And they try also secondary endpoint of the study was to determine type 2 diabetes remission using ADA criteria. So I already showed you weight loss was superior on the Roux-en-Y gastric bypass, but also in type 2 diabetes remission. You see at long term, only 31% of patients that had gastric bypass presented remission of type 2 diabetes. It is true that we used ADA definition criteria, which is very strict and very demanding, versus 9% in the sleeve gastrectomy group. So far, we have that first study that seems to favor clearly the Roux-en-Y. But what about the Stampede study? Dr. Abril mentioned that study early today. That is a randomized controlled trial, IMT versus surgery, 50-50-50, 50 IMT, meaning medical therapy, 50 sleeve versus 50 gastric bypass. This is, again, a randomized controlled trial, one of the most cited papers so far. If we look at the Stampede trial and see 5 years outcomes in terms of weight loss, we see that there is a significant difference in between the Roux-en-Y and the sleeve gastrectomy at 5 years. And not only that, when a Stampede trial led by Phil Schauer, and he looked at type 2 diabetes response to surgery versus medications, we saw that the percent of patients that needed no medications to control her diabetes was significantly higher in patients that had the Roux-en-Y gastric bypass, 45 versus 25. And again, this second study was showing a little bit better outcomes favoring Roux-en-Y versus the sleeve. But What is more recent? So this is the study by Ralph Peterle from Switzerland. This is the SM-BOSS study, randomized controlled trial comparing sleeve gastrectomy versus Roux-en-Y gastric bypass. This study was done, as I said, in Europe, including 4 different medical institutions. They enrolled 217 patients, and you see the groups, 110 had gastric bypass versus 107 sleeve gastrectomy. Importantly, and I want to point this out, let me see if I can. So anyway, there was a 95% retention rate, which is outstanding. So we are looking now at really high quality data. So the main endpoint of Ralph Peterle's study was to evaluate weight loss. That was the main endpoint. And then they had exploratory endpoints, which were changes in comorbidities as well as capturing serious adverse events. So results are as follows. So they saw that, surprisingly, the person who says body BMI loss comparing both groups was not significant. There were no differences among both groups. You see 61% after a sleeve at 5 years versus 68% at 5 years. They saw that type 2 diabetes was slightly, remission was slightly better within the Roux-en-Y, but this was not significant. P-value was 0.7. There were no difference between complications among both groups. So we have this SM-BOSS study, randomized controlled trial, 5 years, both operations are the same. Let's see what else we have. Same year, 2018, JAMA, the paper by Pauliina Salminen from Finland. Again, a randomized controlled trial, Roux-en-Y gastric bypass versus a sleeve. Let's see what they found. Again, multi-center study, 240 patients, follow-up, again, 5 years follow-up. In this case, a little bit of less retention rate, but still very high, providing this is a bariatric paper, 80%. Primary endpoint, weight loss. In terms of percent excess weight loss. So Salminen found that, you see that percent excess weight loss over a 5 years period, there were no difference again. So 2 consecutive randomized controlled trials, finding no differences at 5 years in between both techniques. That starts being a little bit confusing, right? So, and then they also looked at remission of type 2 diabetes. So at 5 years, 12% of patients that did undergo a sleeve had remission versus 25 in the Roux-en-Y gastric bypass group. But again, this was not significant. This was, the p-value at this case was 0.9. It is true that the study was not powered enough to detect differences among groups in terms of type 2 diabetes remission. But then both authors, Ralph Peterle and Pauliina Salminen, decided to merge data from both studies in order to get a more powerful data and to provide clear clues and indications to the bariatric surgery community. This is the study flow diagram, and those are the main outcomes of the combined study. If you look at total weight loss in percent, we see that the Roux-en-Y gastric bypass group is the group on red color, while the sleeve was in blue. You see that total weight loss, Roux-en-Y gastric bypass better, and when they look at excess BMI loss, same, the Roux-en-Y was slightly better again at 5 years. So, not only that, they also saw that hypertension resolution was superior in the gastric bypass group. However, again, no difference in type 2 diabetes, no difference on sleep apnea or quality of life at 5 years. And loss of follow-up was only 13%. Finally, the only study, randomized controlled trial, with a 10 years follow-up available. This is again from the group of Finland, led by Salminen. They did find significant differences between both groups when evaluating weight loss on percent total weight loss and excess BMI loss. A p-value was clearly significant. Percent total body weight loss was 27%. No, sorry, that's mixed. So it was 58% on the roux versus 27% on the sleeve. Again, when they look at type 2 diabetes remission, they didn't find differences among both groups at 10 years on diabetes, on dyslipidemia, on sleep apnea, or prevalence of Barrett. Not surprisingly, patients with esophagitis were more prevalent in the sleeve gastrectomy group. And as was saw before, in the 5 years study, hypertension responds better to the Roux-en-Y gastric bypass. So based on the best quality available data, when we have a patient in our clinic and patient is asking about the Roux-en-Y or the sleeve, if patient has reflux, I think that it is clear that we should lean more towards the gastric bypass. If patient is asking at 10 years, 5 to 10 years, which of both techniques can provide me more weight loss? Again, the data, and I've shown you consistently, Roux-en-Y is better. The same with hypertension. Diabetes, although there's been some inconsistency between the studies that were well designed, still data favors the Roux-en-Y over the sleeve. No differences for sleeve apnea, no differences in quality of life, and maybe, oh, you see the scale is leaning towards clearly to the Roux-en-Y gastric bypass. Maybe patients with IBD would be more in the left side on your screen, favoring a sleeve, as well as patients with multiple surgeries, as well as very high or prohibitive surgical risk. So my key points, as I mentioned, long-term data favors Roux-en-Y over sleeve on weight loss, esophagitis, hypertension, diabetes, not 100% clear, although there are some well-designed studies that support that statement. Finally, my last slide is that both techniques have sustained weight loss over time. Both techniques have shown improvement in comorbidities, but in my opinion, not in my opinion, looking at the best available data, Roux-en-Y gastric bypass should be considered the gold standard technique. Thank you.